The following technical note demonstrates an elongation technique to be utilized for ACL restoration. These are our disclosures. The case begins with a 39-year-old female who tore her ACL approximately 22 days prior to this image. Evaluation of the remaining ACL stump demonstrates a modified Sherman type 3 or borderline type 4 injury. To perform this procedure successfully, we utilize modified portals. In addition to our standard lateral viewing portal, an accessory transpatellar portal is created 5 mm below the inferior portion of the patella, as well as a 2 cm arthrotomy is made adjacent to the patella tendon. Through the transpatellar portal, a spinal needle is used to localize this and then work. After creating this, we can then insert a blunt object to begin teasing away any adhesions and cyclops lesions on the medial and lateral side of the ACL. We try to avoid using electrocautery or a shaver to avoid damage to the remaining ACL fibers and soft tissue. Meticulous dissection and freeing of any adhesions is undertaken to maximize the remaining ACL tissue. After releasing the adhesions, we place a cannula through the 2 cm medial arthrotomy to allow for suture placement into the ACL. Using the transpatellar portal, a grasping device is inserted and we grab the top of the ACL and elongate this towards the top of the notch. This allows for passing of the suture through the ACL stump. The surgeon's preference in this instance is to use a number 2 vicryl suture to be passed with a self-catching device through the ACL stump remnant. Again, through the transpatellar portal, a grasping device is used to elongate the ACL, allowing for as many passes as possible through the ACL with good tissue bite. Once the torn segment of ACL has been captured by the number 2 vicryl suture, any remaining fibers attached to the femoral wall can then be incorporated into this, again using the self-catching device. The knee position can be changed from a 90-degree flex position into a hyperflex position to allow for better visualization and access to the ACL remaining fibers attached to the femoral wall. Suture can also be passed through the ACL torn remnant as well as the remaining tissue to allow for incorporation in a uniform manner. After completing the passes required to obtain good fixation on the ACL stump, the ACL can then be fixated based upon surgeon preference with either an anchor into the intercondylar notch or by making a small hole through the femoral wall and tying this over a button or staple on the lateral femoral condyle. Introduction of the biologic augment can also be introduced over top of these sutures. The ACL is placed up against the wall, demonstrating return to its anatomic location after elongation.